students. Do good for others. It will come back in unexpected ways. So as we are in Christmas weeks, do something for others. Today we are going to discuss about the topic Cephalo Pelvic Disproportion and the contracted pelvis. First we can see what is Cephalo Pelvic Disproportion. So you can see from this picture, the baby's head is too large and pelvis, so it is not accommodate properly in the pelvis. This is Cephalopelvic disproportion. We can see the definition. Cephalopelvic disproportion is the disparity. Disparity means the head and the pelvis is not properly accommodated in relation between the head of the baby and the maternal pelvis. So that is the Cephalopelvic disproportion. So it is a disparity between the fetal head and the maternal pelvis. It is a pelvis in which one or more of its diameters is reduced below the normal by 1 or more centimeters. So in the centimeters it is not proportional to the fetal pelvis is not proportional to the fetal head diameter. It is known as Cephalopelvic disproportion. We can see the degree of disproportion. It is based on the clinical finding and the pelvimetry. First, severe disproportion. When the obstetrical conjugate, you already know the obstetrical conjugate, when it is less than 7.5 cm or 3 inches, then it is said to be severe disproportion. Then borderline disproportion, when the obstetrical conjugate is between 9.5 to 10 cm. The inlet, the anterior posterior diameter is less than 10 cm and the transverse diameter is less than 12 cm. That is a borderline disproportion. So that is based on clinical finding and pelvimetry. There is severe disproportion and the borderline disproportion. The incidents are about in American College of Nursing and Midwives, they did the study in that about 20 women are with the Cephalopelvic disproportion in about 250 pregnancy. It has been seen through the studies that 65% of women who have been diagnosed with Cephalopelvic disproportion in previous pregnancies deliver vaginally in the subsequent pregnancy. We can see the causes. First is the nutritional deficiency. So nutritional deficiency. Second is disease or injury to the pelvic bone. Next, developmental defects. In a large baby, when the baby is large, it will not accommodate properly in the pelvis. So that will cause the Cephalopelvic disproportion. Next, abnormal fetal position, that is in the posterior or face presentation or breech. So up the transverse, so abnormal position that also will not accommodate properly in the pelvis. And problem with the genital tract. These are the causes of Cephalopelvic disproportion. We can see the classification of these causes, that is absolute causes and the relative causes. Absolute causes. It is a true mechanical obstruction due to permanent maternal cause such as contracted pelvis, anterior sacrococcygeal tumor. So that is the permanent. This is a permanent causes. It cannot be changed. And temporary fetal causes such as hydrocephalus, because that baby had hydrocephalus, that's why it is not accommodated properly in the pelvis, and because of the large baby. So in the first pregnancy, if the baby is large and there is Cephalopelvic disproportion, there is no chance of second delivery. There is a chance of Cephalopelvic disproportion only because of the large baby. That is a temporary fetal causes. Next is relative cause. The relative cause include broad presentation, face presentation, menopause, the diameter is too large, and that is occipital posterior position, deflex head in vertex presentation. All these presentation, the diameter will be large enough, so it will not properly accommodate in the pelvis diameters. That is a classification, that is absolute causes, that is permanent maternal cause and temporary fetal cause. And next we see the relative causes. Now we can see the contracted pelvis. We already said because of the contracted pelvis there is chance of because of contracted pelvis chance is Cephalopelvic disproportion. So what is a contracted pelvis? Anatomical, the essential diameters of one or more planes are shortened by 0.5 centimeters. So when the diameters of the pelvis is shortened, but that is 0.5 centimeter, it is known as the anatomical contracted pelvis. Next is obstetric. It is a pelvis in which one or more of its diameters is reduced so that it interferes. Means തടസ്സപ്പെടുത്തുക with the normal mechanism of labor. Because of one or more diameters are reduced, that interferes with the normal mechanism of labor, that is in the contracted. That is obstetric. We can see the etiology. The common causes of contracted pelvis are nutritional and environmental defects. That is minor variations, that is usually common, and major, that is rickety and osteomyelitic type of pelvis are the major. That is the nutritional and environmental defects. Second is disease or injury affecting the bones of the pelvis. That is the pelvis problems affecting because of the disease are fracture, tumor, tubercular arthritis. In the spine, such as kyphosis, you can see from this picture kyphosis, scoliosis. This is scoliosis. This is twisting and coxillear deformity. Next is the lower limbs such as poliomyelitis, hip joint disease. Next is the third, that is the developmental defects. First is necklace pelvis. Second is the Robert's pelvis. What is necklace pelvis? This type of pelvis is extremely rare and it is produced due to the arrested development of the one ala of the sacrum. So that is the necklace pelvis. You can see from this picture, that is the main characteristics is the congenital and acquired the congenital variety may be associated with urinary tract with the same side. The pelvic is obliquely contracted. Main feature of this necklace pelvis in this one, the obstetric obliquity contracted, that is at all levels but more marked in the outlet. Obliquity is a mainly contracted. So that is a Nagel's pelvis. Next is Robert's pelvis. In the Robert's pelvis, transversely contracted. In this Nagel's pelvis, it's obliquely contracted, but in the Robert's pelvis, that is transversely contracted. And this is an extremely rare abnormality, that is the Robert's pelvis. And high or low assimilation pelvis. So this is the etiology that is we already said nutrition and environmental defects, disease or injury affecting the bone, that is pelvis, spine, lower limbs and developmental defects. Next we can see the classification. There are two types we can be classified. First, the type of distortion of the pelvic architecture. And second is degree of the contraction. So each one we can see in detail. So first is the classification by pelvic architecture. First is the pelvis accumulator Jesco minor. So pelvic accumulator Jesco minor. It is characterized by general reduction of all diameters. You can see from the Jesco minor pelvis. So that is a reduction of all diameters, equally shortened usually by 1 to 2 cm. So equally shortened by all sides by 1 to 2 cm. Then occurs in short. Also occurs in women with massive skeletal bones and developmental muscles. Their pelvis has masculine features such as narrow sacrum, narrow pubic outlet. That is usually funnel shape. This is the pelvis with the accumulator Jesco minor. So the main features that is reduction of the all diameters by 1 to 2 cm. You can see from this picture. Next is flat pelvis. The reduced antero-posterior diameter with the normal, transverse and oblique diameters. So in this one, only the antero-posterior diameter is reduced. Other normal, that is the transverse and oblique diameters are normal. It has also two types of contracture, that is simple flat pelvis and flat rickety pelvis. That is simple flat pelvis, that is entire sacral platform is dislocated towards the symphysis pubis. Hence, all the antero-posterior diameters of all pelvis planes are reduced. It is the sacral platform. This is a sacral platform is dislocated towards the symphysis. It is dislocated towards the symphysis. So that's why all the antero-posterior diameter will be reduced. Then next is a flat rickety pelvis. So in this antero-posterior diameter of the pelvis, inlet only. In this one simple flat, we already said it is all diameter, the antero-posterior diameter will be reduced. But in the flat rickety, it's only the inlet only reduced. Antero-posterior diameter of the inlet only reduced. So that is the second one, flat pelvis. Third one, generally contracted pelvis. All diameters reduced, but antero-posterior diameters are short and greater than others. It is the all diameters are reduced, the antero-posterior, transverse and oblique. But the main thing is only the antero-posterior diameter shorter than the other diameters and usually connected with the rickets of the child. You can see from this picture. Next, various forms of contracted pelvis. First, otose pelvis. You can see from this picture, develop as a result of inflammatory process of the hip or knee. So, when there is a inflammatory process happens in the hip or knee, this type of this otose pelvis usually occur. Then, beaked rostrate pelvis. The underdevelopment of the both sacral wings. The sacral wings underdevelopment, that's why it is the beaked pelvis occurs. Next is the spondylolithic pelvis. Spondylolithic pelvis, it is formed due to, you can see from this picture, it is formed due to the partial dislocation of the last lumbar vertebrae. Last lumbar vertebrae, there is a partial dislocation occur in front of the first sacral. This is the first sacral vertebrae. So the last lumbar vertebrae, there is a partial dislocation occurs. Okay. Then next is osteomalacic pelvis. It is caused by softening of the pubic bone. You can see from this picture, it is usually occurs by the softening of the pubic bone due to the deficiency of calcium and vitamin D3 and lack of exposure to sun rays. The promontory is pulled downward. You can see sacral. This is the sacral promontory. So sacral promontory is pushed downward and forward, and the lateral walls are pushed inwards, causing the anterior wall to form like a beak. Okay, so this is the osteomalacic pelvis. Then is a scoliotic pelvis. Only one lumbar region causes deformity of the pelvis. The acetabulum is pushed inward on the weight bearing side. That is a scoliotic pelvis. Next we can see the first we see the types of dislocation of pelvic architecture. Next is the classification by the degree of contraction. So in that one there are 4 degrees are there. So first, true conjugate will be less than 11 cm but not less than 9 cm. Then spontaneous deliveries will be possible. But in second degree, true conjugate, that is 9 to 7.5 cm. Spontaneous delivery possible, but some complication may arise. In third degree, true conjugate, that will be from 7.5 to 6 cm. So spontaneous delivery is impossible. So there should be the case should be go for the cesarean section. And fourth degree, true conjugate, that is less than 6 centimeter, and the delivery is impossible. Always cesarean section, also known as absolutely contracted pelvis. So according to the degree of contracture, the classifications of first degree, second, third and the fourth degree. Next is the diagnosis. The history. You have to take the history of rickets is expected if there is a history of delayed walking and the dentination. Trauma or disease of the pelvis, spines or lower limbs. Then osteomalacia, previous tuberculosis of the bones and the joints. So we have to take this history. Then bad obstetrical history, like prolonged labor ended by. So we have to ask them about the previous delivery, about if it was the prolonged labor, and at the end it was delivered by difficult forceps, cesarean section or stillbirth. Okay, then weight of the baby, how much was the weight in the previous pregnancy, and evidence of maternal injury such as due to in the first delivery, after delivery, is she had any complete perineal tear or vesicovaginal fistula, rectovaginal fistula. So we have to take this history, that is a bad obstetrical history to be taken. Then general examination, abnormal gait, that is assess woman for stockily built with a bull neck. Stockily built means a short structure with the wide shoulders. Okay, then shoulder and short thigh. Then obese and male distribution of hair. So that is the abnormal gait. Then stature, that is a woman that is less than 150 centimeter or 5 feet. That is a general examination. Next is the abdominal exam. You have to check for pendulous abdomen. Pendulous means it is sagged in front. This pendulous abdomen in primary gravida, and fetal head fails to enter a contracted pelvis at the end of the pregnancy and floats high above the inlet. So it will not be engaged. So failed growth of uterus deviates upward and anteriorly. So then non-engagement in last 3 to 4 weeks in the primary. Usually the engagement take place in the later weeks of that. After the 36 weeks, usually engagement will take place in a primary gravida. If they are not engaged after the 4 weeks in the primary gravida, so all these indicate the contracted pelvis. And next, shape of the abdomen, I want to say pendulous abdomen. You can see this is the pendulous. The acuminate, it's pointed abdomen. You can see this is the point. മുന്നോട്ട് തള്ളി നിൽക്കുന്ന വയറെന്ന് പറയും. So that is the acuminate or pointed abdomen in primary gravida with a resilient abdominal wall. Then pendulous abdomen in the multiparous woman. You can see this is the multiparous woman. It is a pointed or accumulate abdomen in the primary gravida. So that is the shape of the abdomen. You can see the abdominal method in the Cephalopelvic disproportion. So how to assess the Cephalopelvic disproportion in the abdominal method? The patient is placed in the dorsal position with the thighs flexed and separated. Then the head is grasped by left hand. You can see from, you have to stand in the right side of the mother and you have to grasp the head by the left hand. This is the grasping the head. Then two fingers, that is index and middle fingers, is placed above the symphysis pubis. It is kept above the symphysis pubis to know the degree of overlapping. How can we see? That is, when we are pushing with your left hand, downward and backward. So that time you can feel here with your hand the overlapping. That is the method. This is with your left hand. You can hold or grasp the head with your right hand. Two fingers you have to keep the above the symphysis pubis, so you can see the overlapping. So how much is the overlapping and how can we understand? The head can be pushed down in the pelvis without overlapping of the parietal bone or the symphysis pelvis, so there is no disproportion. The head can be pushed down a little, but there is slightly over. You can feel with your right hand, you can see the overlapping. So slightly overlapping of the parietal bone, evidenced by touch on the under surface of the finger overlapping by 0.5 cm. So that is known as disproportion, that is moderate disproportion. Then third, the head cannot be pushed down and instead the parietal bone overhangs the symphysis pubis, displacing the finger. That is the severe disproportion. So we cannot push the head inside. So what will happen if we try to push the parietal bones overhangs and the symphysis pubis, so displacing our finger. So that is a severe disproportion. Sometimes the degree of disproportion is difficult to find out by this method because of deflex head, thick abdominal wall, irritable uterus and high floating head. So sometimes we cannot do this method because of these reasons. Next, abdomino-vaginal method. It is also called as Muller's-Munro curve method. It is bimanual method. So this is by both hands. One hand per vaginally and second hand by abdominally. So the result, the head can be pushed down up to the level of ischial spines. Same like the hand which is placed on the abdomen. So there is no overlapping of the parietal bone over the symphysis pubis, so there is no disproportion. The head can be pushed down a little but not up to the level of ischial spines. Then there is a slight overlapping of the parietal bone. It is a slight or moderate disproportion. The head cannot be pushed down and instead of parietal bone overhangs the symphysis pubis, displacing the thumb. We already said all this in the abdomen. It is a severe disproportion. This is the pelvimetry. So it is assessment of pelvic diameters and capacity done at 38 to 39 weeks. It includes clinical pelvimetry, that is internal pelvimetry or for inlet cavity and outlet, external pelvimetry for inlet and outlet. This is the pelvimetry. We are using the instrument for the pelvimetry. Next is the imaging pelvimetry. Imaging pelvimetry include the X-ray pelvimetry, computerized tomography and a magnetic resonance imaging. So we can see one. So clinical pelvimetry. The time of doing the clinical pelvimetry is in vertex presentation and the assessment is done at any time beyond 37th week but better at the beginning of the labor. Because of softening of the tissues, assessment can be done effectively during the time of beginning of labor. The procedure, the patient is to be empty the bladder. The pelvic examination is done with the patient in dorsal position taking aseptic preparations. The following features are to be noted simultaneously if you are doing the clinical pelvimetry. State of the cervix, to note the station of the presenting part in relation to the ischial spines, that is a station. To test for cephalopelvic disproportion in non-engaged head, to note the resilience and elasticity of the perineal muscle. So the steps. The internal examination should be done with the two fingers. We can do the internal examination to methodical and purposeful. And it should be emphasized that the sterilized gloves, the finger once taken out should not be reused. So when you introduce the hand inside, you have to check all the findings. First, sacrum. This is the method of doing the sacrum. The sacrum is moved. Well, when we are introducing the hand straight, we can feel the sacrum. The sacrum is moved, well curved and usually inaccessible beyond lower 3 pieces. You can see the 3 pieces. Beyond the 3 pieces we cannot be accessible. The length, breadth and its curvature from above, down and sides walls to be checked. You have to check the side wall and above, down should be checked. Second, that is sacro-sciatic notch. The notch is sufficiently wide. So this is the second. We are checking the sacro-sciatic notch. The notch is sufficiently wide so that 2 fingers can be easily placed. You can see in between 2 fingers can be easily placed over the sacrospinous ligament covering the notch. So it is covered by the sacrospinous ligament. So we can keep 2 fingers over them. The configuration of the notch denotes the capacity of the posterior segment of the pelvis and the side walls of the lower pelvis. So first we check the sacrum. Second we check the sacro-sciatic notch. Next, say ischial spines. This is the, you can see the prominent ischial spines. So after introduction of the hand, we can move to both sides. So spines are usually smooth and difficult to palpate. They may be prominent and encroach to the cavity, thereby diminishing the available space in the middle. The abnormality can be seen like it is a prominent, sharp. That means it is abnormality. Otherwise, we will feel the pelvis and check the station. So, according to the relationship of the ischial spine, we are check the head and the ischial spine. The relationship. Let's check the station. Then iliopectineal lines. So this is the iliopectineal line. Okay, to note for any breaking suggestive of narrow forepelvis, that is the android pelvis. You can see check for any breaking in the iliopectineal line. In this line, we have to check for any breaking. Then side walls. Normally they are not easily palpable by the sweeping fingers unless convergent. Convergent, if it is convergent only we can see. Otherwise, unless convergent, we cannot do this one. Then posterior surface of the symphysis. This is the posterior surface of the symphysis. It normally forms a smooth round curve, and the presence of agglutination or breaking suggests there is an abnormality. You have to check the posterior surface of the anterior posterior surface of the symphysis. Next is sacrococcygeal joint. Its mobility and the presence of hooked coccyx, if any, are not. This here is the sacro. When you are moving the hand in front, here the sacrococcygeal joint can be palpated. Then pubic arch. Normally the pubic arch is rounded and should accommodate the palmar aspect of the 2 fingers, and the configuration of the arch is more important than the pubic angle. So next is the diagonal conjugate. So diagonal conjugate is measure. You already studied in previous classes. So this is how we are measuring the diagonal. Keep your finger introduce the finger. You have to keep the finger touch the sacral promontory. Then how much is the is introduced inside. So that is measured by the diagonal conjugate until the sacral promontory. Okay, below the sacral promontory is the diagonal conjugate. Next is the pubic angle. The inferior pubic rami are defined, and in female the angle roughly corresponds to the fully abducted thumb. You can see fully abducted thumb and the index finger, abduct thumb and the index finger. In narrow angle, it roughly corresponds to fully abducted middle and index finger. You can see this is reduced one. This is 9. This is 180. This is more abducted one. Okay. Then transverse diameter of the outlet. It is measured by placing the knuckles of the first interphacial joints or knuckles of the clenched fist between the ischial tuberoses. That is a transverse diameter can be. That is measured by like this. You can see clenched hand. So here, from here to here, we can palpate. That is by the measure, we can measure the transverse diameter of the outlet. We can measure it. So we have, after the obstetric conjugate, we have to remove the hand. Then you have to do these measurements. Okay. Then anteroposterior diameter of the outlet. The distance between the inferior margin of the symphysis pubis, and the skin over the sacrococcygeal joint can be measured either with the method employed by the same how we measure by diagonal conjugate. Same method we can measure the anteroposterior diameter of the outlet by external calipers. Next, we can see the effects of the contracted pelvis. In pregnancy, the general course of pregnancy is not much affected. However, the following may be occur. There is more chance of incarceration of the retrovertebral graviduterus in flat pelvis. The abdomen becomes pendulous, especially in the multigravida with lax abdominal wall. So, abdomen becomes pendulous. We already see in the picture, so especially in the multigravida with lax abdominal wall because of the second pregnancy. Then malpresentations are increased, that is 3 to 4 times, and also increase the frequency of unstable. There is a more chance of unstable life. In labor, the course of events in labor is greatly modified depending upon the degree of pelvic contraction and presentation of the fetus. So, there is increased incidence of early rupture of membrane. So, because if early rupture of membrane occur and the head is not engaged, what will happen? There is a space in between the head and the pelvis. So, there is a chance the incidence of cord prolapse is increased, and cervical dilatation also slowed. There is increased tendency of prolonged labor, and in neglected cases, obstructed labor with features of exhaustion, dehydration, ketoacidosis, and sepsis occur. And there is increased incidence of operative interference such as vacuum or the force, and shock, postpartum and hemorrhage and sepsis may be occur during the labor. Next, maternal injuries. The injuries of the genital tract may occur spontaneously or following the operative delivery. There is increased maternal morbidity and the mortality. Next is the fetal hazards. The fetal risks are due to the trauma and the asphyxia. The net effects leads to increased perinatal mortality and the morbidity. Next, we can see the management. So, if the disproportion according to the severity is moderate or severe, we are doing the management according to the type or degree. So, if the moderate and baby is on preterm labor, we have to go for the induction of labor. And severe degree and term baby, we have to go for the cesarean section or the trial labor. In the cesarean section, elective cesarean section, a term is indicated in major degree of contraction, major disproportion, absolute contraction, dead fetus, patient not fit for trial labor. The operation is done in planned way any time during the last week of pregnancy. Then emergency when the trial labor is failed. This is about the cesarean section. In trial labor, it is a condition of spontaneous labor in a moderate degree of disproportion in an institution under supervision with a watchful expectancy hoping for the vaginal labor. That is a trial labor. Then trial of labor is a test of labor. We are testing that labor occur or not, allowing the patient to enter into active labor, putting all variables like power, passage and passenger into test and determine whether vaginal delivery is possible, or we are trying to test testing that vaginal delivery can be done or cannot be done. That is the trial labor. Next, conduction of trial labor. How we can conduct the trial labor? Careful fetal and maternal monitoring by the electronic fetal monitoring and the non-stress test. That because there is a chance of fetal distress. And oral feeding remains suspended. We will not give any oral feeding because there is we may go for it. The case may go for the cesarean section. So oral feeding remains suspended and hydration is maintained by intravenous. Also oral feeding should not be given. Only IV fluid should be given. Then adequate analgesics is administered because patient will be having severe pain. So analgesics can be administered. Then augmentation of labor by pitocin should be done. The progress of labor is mapped with the diagram. The progressive descent of the head, progressive dilatation of cervix should be, that is the progress of labor. We are checking by descent and the dilatation of cervix. And after the membrane rupture, the pelvic examination is to be done because there is a chance of cord prolapse. So that's why we have to do the pelvic examination or pervaginal examination to exclude or to check for cord prolapse, to note the color of the liquor, to assess the pelvis once or more, then to note the condition of the cervix, including pressure of the presenting part of the cervix. So this should be checked. Then, in favorable cases, end spontaneously, low forceps and low ventouse. If favorable cases are if trial labor is properly progressing, but end with what? Forceps delivery or the ventouse. In unfavorable cases, we may watch for a long time, but it should not be end properly. That's why maybe there is a chance of fetal distress or any cord prolapse or any meconium stain liquor. So we may go for the cesarean section. Then successful trial. If it is successful trial, a trial is called successful if the healthy baby is born vaginally, spontaneous, or by forceps or ventouse with the mother is in good condition. That is known as successful trial labor. Then failure of trial labor, that means delivery is by cesarean section or delivery of the dead baby spontaneously or by craniotomy is called failure of trial labor. But next we can see what are the advantages of trial labor and disadvantages of trial labor. So lower incidence of cesarean section. We can, if we try the trial of labor done, then we can reduce the incidence of cesarean section. And successful trial ensures the woman a good future obstetrics. Otherwise, she may be very sad. Then disadvantages of trial labor may end before full dilatation. That may end before full cervical dilatation. Then increase the fetal mortality and morbidity. In failed trial, operative risk increases. So these are the advantages and disadvantages of trial labor. Next we can see the nursing management. So as we are nurses, we have to record properly the progress of labor. So check vitals every 4th hourly, monitor both contraction and fetus continuously, report immediately the sign of fetal distress, and position the mother in ways to increase the pelvis diameter, such as sitting or squatting with increase the outlet diameter and also aid in the fetal descent. So we can allow the woman to use the different positions. So the diameter, pelvic diameter may be increased. Then assess the fetus for hypoxia and provide support to the client and the family members in coping with the stress of the complicated labor. These are the nursing management. So next we can see what all the problems may arise due to the trial labor. Second stage, delayed second stage, and there is a chance of shoulder dystocia due to the decreased anteroposterior diameter. Then the third stage, there is a chance of retained placenta, postpartum hemorrhage, maternal injury. So that's all about the Cephalo Pelvic Disproportion and contracted pelvis. I think all of you are clearly understood. Thank you once again.